So I just moved out here from Los Angeles last year, and I was very blessed to train with Neil Nahn out at Cedars-Sinai. He taught me all about MIS and MIS deformity and putting in screws and doing fusion. And I think, obviously there's a lot of patients that have a deformity, they can't get an arthroplasty, and they need a deformity correction. That's a different game here. But I have a very unique practice. I'm now calling myself an arthroplasty surgeon because that's what I like to do. I would prefer only to do that. I mean, that's just everyone. We all find our niche and what we like to do, and that's my favorite thing. So I'm now I'm kind of gearing this. Why not arthroplasty? That's I see so many patients that come in, they don't want a fusion, and so I'm looking at them trying to figure out, can I avoid fusion? Is there a way that we can avoid it? And why is nobody else doing arthroplasty, right? And so, I think there are a lot of reasons, and some of them are good, but there are a lot of excuses that are used by other surgeons. And hopefully, Dr. Blumenthal can defend me at the end of the talk. The one I hear most often is the disc is too collapsed, and we heard earlier 2 talks ago used a particular number. I think that's BS. I'll show you some cases why that's BS. There's a spondylolisthesis. Obviously if it's a unstable spondylolisthesis, if it's a grade 2+ spondylolisthesis, that's a reason, not an excuse. But if it's a mild spondylolisthesis, we can do it. And the facet joints or joint are too arthritic. That's another one I hear all the time. And the surgeon didn't even get a CT scan. So how are they evaluating the facet joint, right? And the patient is too old. That's the other thing that drives me crazy is especially in this day and age. We have patients, especially in South Florida. I mean, they're coming to retire. They want to golf. They want to do their activities, and why should they be forced into a fusion? So I think that's a bad excuse a lot of times. And a couple examples, you may think I'm crazy, but this is a 74-year-old, which a lot of surgeons would do a big deformity correction. In my training, this patient would have gotten a T10 to pelvis with most surgeons that they saw. So this is an example of trying to avoid that big fusion, and so I was able to do the surgery all anterior well, not all anterior. The next one's all anterior. She had a pretty significant slip. This one I was able to do all anterior, and I do like the standalone. That's one thing I agree with. I do like standalone A-lifts when I have to do a fusion. That's my preferred lumbar fusion technique. And both these patients are very, very happy. They're doing all the activities they want to do, and hopefully this is the last surgery that they'll have to have. And I'm not doing an extension of fusion because I saw a lot of those patients earlier in my practice, and they come back oftentimes. Sure, not every patient gets adjacent segment degeneration, but the bigger the fusion, I think the more likely they are to need that extension of fusion. So, really my philosophy now is I'm not just thinking about tomorrow, I'm trying to think about 10 years, and I'm really trying to avoid this. I really do think it's bad for people. I really do think that this is non-physiologic. I think that, flexibility is the way our spine is, supposed to be, right? We're supposed to be flexible, we're supposed to move. Movement is life. So my strategy is really all motion preservation if possible. If I have to fuse a level, I try not to end with it on top. So, all joking aside, the ADR sandwich is a way to just minimize fusion, right? And I'll show a few of those. But I'm really trying to also talk about indications. I do agree that we do have to be careful to not cause problems because a failed ADR is very difficult to deal with, right? So I think you do have to be careful about patient selection, and there are many, many patients that I am not performing disc replacement on, and obviously those aren't getting shown in the talks, right? But I really think for discogenic low back pain, right, with or without radiculopathy, and I think some patients, if they have posterior bony stenosis and only leg pain, I'm offering them a decompression minimally invasively, not an ADR as their first surgery, right? disc herniations with low back pain. They're not amenable to microdiscectomy, like these broad-based disc herniations. If they have a recurrent disc herniation, like Scott said, that can be a very good indication. Recurrent disc herniation, recurrent leg pain, plus back pain, I think that's a great indication for an ADR. You've really got to be careful with bone density. Can't stress this enough. Every patient I get a DEXA scan on, every single patient. Even the 45-year-old male who thinks he's healthy. I mean, now I'm getting them on pretty much everybody, right? So osteopenia, and I'm going to show some controversial cases. You can get away with it if you're careful. Osteoporosis, no, you've got to treat them. And I've done osteoporotic patients, treated them with Forteo for 6 months, and then done the ADR, and then done cement. And I'll go over some of those cases. Prior surgery at the index level, you've got to really evaluate the facet joints with a CT. And I get CTs on pretty much every patient pre-op. If they're severely collapsed disc space and a history of prior microdiscectomy, did the previous surgeon take out the whole facet joint, right? You need to know that, especially at L5S1. Sacral slope. My personal cutoff in the past has been 45 degrees, not based on any scientific data, but the ProDisc biomechanical studies look at the force to failure, and the force needed to cause a failure of the poly is significantly less when you get up past 45 degrees. So that was a prior cutoff. Now with the new modular end plates they have, I go up to 50 degrees now. Okay. So facet joints, I've loosened the indications more and more when it comes to the facet joints. I think they're less important, right? Anterior listhesis. If they have a small listhesis due to disc space collapse, a lot of these early spondylolisthesis, before the facets get completely trashed and they become grade 2, they're because of anterior collapse when the disc collapses. All right, and then pars fractures, you have to be careful about those. Right. So I think you have to take everything into consideration: the patient age, their lifestyle and goals, their history and physical, obviously, and you need to have an accurate diagnosis. As we discussed earlier, you need to really know that disc is causing the pain. Otherwise, you're going to have a failed surgery, even if you do a perfect surgery, right? Does the sacral slope really matter? And that's, I think it's still an unknown. There have been a couple of small papers from the same institution out in LA, and they showed different results, but they're both small. This study showed it didn't really matter. Another paper they published showed maybe the patients with higher slope have worse outcomes. I only show this because we didn't used to have this in the US. Now we have it as of the last couple of years, the more modular end plates. We can build up the sacrum a little bit, so I think we can go a little bit steeper on the slope at L5S1. Okay. So contraindications or cautions. So above L3 is always going to be off-label. And I've done L1-2s and 2-3s, right? Simultaneous ADR next to a fusion is technically off-label, so you're not going to get that approved by the insurance company. 3 levels off-label, you're not going to get approved by the insurance company. You have to be careful with small patients and big patients. These implants are made for the average patient, unfortunately, but we need a bigger implant for the guy that's 6'5" and 275. We need a smaller implant for the woman who's 5'2" and 105, right? And then significant scoliosis, and Dr. Marnay has shown some cases, but I think you have to be really careful with that. And you don't want to see this. This is subsidence. This is a patient that has very big vertebral bodies. Now I measure every single level that I'm going to do an arthroplasty on. I look at the cross section, both the anterior, posterior, and medial to lateral dimensions, and I compare that to the dimensions of the implant. If there's a big mismatch on a big patient, you've got to be really careful or not do it. If it's a small patient, it's going to be too big. Obviously, you're going to have a problem there. So some cases for fun, this is kind of what I love to do. Stuntman, 66-year-old guy out in LA. He's done all the Fast and Furious movies. He's the guy that crashes the car in the truck. Truck's behind the scene, but you don't see him in the movies. But bad back pain, collapsed at every single level. He's in his 60s. He wants to keep working for 10 more years or whatever. What do you do with this guy? Look, every single level is trash. His pain is all low, right? He doesn't really have much in the way of lateral recess or foraminal stenosis. It's all collapsed. So are you gonna do a 3-level fusion on him? I mean, or just no surgery? Tell him to live with his pain? So that's a tough case, right? And this is a case I put in there because everyone else says you can't do a disc replacement when they're collapsed, right? Well, if you really work at it during surgery and you're careful about it, you can get these open. Sequentially, you have to do your releases. It's definitely possible. L5S1 was very stiff. I had to use the David spreader on this to eventually get it open, but got it open, and he's very, very happy. His back pain's gone. He went back to work, crashing cars pretty shortly thereafter. Right? How about this gentleman, 66-year-old, ex-military, low back pain, radicular pain. He's got spondylolisthesis, so this is the case to counter the spondylolisthesis, right? 3-4. But look, I mean, it doesn't really move, right? This is my most common listhesis case I see in my office. They're not all mobile. Most of them are not mobile. So I don't think you really have to fuse it. He's got lateral recess stenosis. You have to watch out for that, right? It's bony stenosis, is why I get a CT scan. So to me, that needs to be decompressed posteriorly, directly. I know some people think you always can get away with indirect decompression. I don't believe that. So this patient, I took him to the OR for a 2-level disc replacement, those 2 levels. I flipped him at the same time at that upper level and took care of the lateral recess stenosis, taking care to not damage the facet joints. And he's very happy. He's now almost 4 years post-op. All right. How about this gentleman, 65 years old, but in excellent condition. He's one of the gym rats. He's in the gym every day for hours and hours a day. And he's got 3-level disc space collapse, right? Are you going to fuse him? I mean, I don't know what else to do for these patients other than not operate on them because they don't want a big fusion. So this is another case, very collapsed, and was able to get him open. And by the way, this I did outpatient. So we talked earlier about outpatient versus inpatient. I did do a couple of studies showing the safety of this, but there's a lot of factors involved. Patient factors. You have to have a very, very smooth, fast vascular surgeon. You have to have a really good team to do it safely, right? 65-year-old gentleman, big patient. You have to be careful with this. The L5S1 facet joints were almost auto-fused. This guy could hardly walk, but he didn't want a fusion. So I warned him about all the potential problems. Standalone ALIF at the bottom and 3 levels on top. We got him pretty straight. He had a lot of pain for the first year, but the facet joint pain eventually went away, and he's very happy. He's now 4 years out. And so hopefully I saved him a T10 to pelvis fusion, right? How about this patient, 38-year-old patient, surfer, 3 prior microdiscectomies, 3 prior. And he's got back pain, leg pain. Look at 3-4, left-sided recurrent herniation, 4-5, right-sided recurrent herniation. Right, he's got L5S1, left-sided herniation. He's got bilateral radiculopathy. Are you going to go do another microdisc on him? He's got back pain. I always get standing x-rays. Look at how collapsed the 4-5 is. All 3 of the levels are very collapsed, right? So I always get the CT scan. Now look at the facet joints carefully. Look at the 3-4 level. The prior surgeon took a little bit of the facet joint, but the right side's intact, left side's more than 50% intact. The one below at the 4-5 though, both sides are I think, in my opinion, too far gone, right? So this is all joking aside, the ADR sandwich case that he was pulled up earlier. So, ALIF between, and he's got good motion above and below. So I'm hopefully avoiding the adjacent segment degeneration. He's only 38. He's back to surfing. So I think that's a good indication for that. Now, what about this adjacent segment degeneration? This patient had an old fusion. He did well for many years, right? But the level above is bad. He's got back pain, pretty severe. The facet joints at the level above were pretty destroyed, not only by the screws being there, but degeneration. So I did a standalone ALIF at the level above and ADR above that. All right. So hopefully there's another case of a long long segment fusion avoided, I'm hoping. All right. And what about this? This, you have to be very careful with the lateral translation. This, you cannot ADR this. I mean, he's got pelvic obliquity and lateral translation with a rotation. At that level, you see CT scan shows some translation. So this case, we're able to sort of build a stable platform parallel to the floor by correcting that deformity with the anterior and posterior fixation, and then top him off with the disc replacement. And now he's a year and a half out and doing very, very well. Of course, I'm only showing you the good cases, right? So also a young guy, 45-year-old patient, severe disc degeneration at the upper level, moderate at the lower two levels. This, I think, was a good case for hybrid. This patient is now 5 years out, and the 72-year-old I showed you earlier, that's his mom, who I did more recently. This is a 56-year-old pilot, veteran, chronic low back pain. I show you this case because this is a discussion of the facet joints. So you look on the left side, 3-4, he has an old facet fracture, so he's got some damage there. And so, I had a long conversation with him. I said, look, you may have some post-op back pain. At that level, we can treat it with rhizotomies if that comes up. But he didn't want a fusion, wanted to try to avoid it. So we ended up going ahead and doing the ADR even at that level. He actually kind of disappeared, but a few years later he gave a review that said he was pain-free. So hopefully his implants look okay. What do you do with osteopenia? You have to, as I mentioned, you have to be very, very careful. This is a 64-year-old lady. So I went ahead and did it. She was kind of borderline osteopenia, osteoporosis. The few things you have to take into consideration. So I cemented around the keels, under the end plates, and then you see I have complete ADP implant coverage. It's very hard for implant to subside if it covers the entire end plate. At least that's my opinion, my theory. So far it's worked out for me. Hopefully I don't get burned. This is a 61-year-old with a large cystic defect. I wasn't sure, right? This is the first one I had with a big cyst like that. I said, well, look, intraoperatively, we may have to convert you to a fusion if I don't think it's going to hold it, but I'll see if I can fill it with cement. And so I did, I just used the Medtronic anterior cannulas and bone cement, right? So I'm not just a user, a believer. I'm a believer because I have one in my own body that I've had for the last 5 years. That was me. And by the way, I had almost no back pain. I had leg pain. I had radiculopathy. But I'd already had 2 microdiscectomies and nothing was working. So I ended up getting a disc replacement myself, and that took care of the problem because the foraminal height loss was my problem. All right. So thank you very much.